right? Now, if you look at hypercalcemia, we agreed that typically you don't see too much of this. When you do, you have a patient who usually on most tests and most people, they're hyperparathyroid. Most of the time, if I'm going to get a high calcium, it's going to be because they have a hyperactive parathyroid or they have a complication of cancer. Those are the two times that I see that the most. Now, everything is down, which is weird for calcium. It sounds weird, but if you'll remember when I told you about a low calcium, things was hyper. They was seizing, they was kicking you in your chin, they was doing all kind of crazy shit. That was a low calcium, remember? Spasms and, ooh. This is a high calcium, everything's low. So, we don't have a lot going on in our GI system. It's low. Constipation. Our pulse, usually low. How low can it go? Heart block. What's going on the EKG? Even the damn T-wave is depressed. Everybody low. It's not that hard. Because you know what I taught you over there. That me and you was in Walmart and a low calcium is just the opposite. This one's high. Everything is kind of low. Okay? Now, never due to your diet. You can't make yourself go high. It's not going to happen. You typically will not make yourself high drinking a ton of milk. You may get some other shit going on, but this is not due to dietary intake. Okay? It's due to, again, hyperparathyroid, cancer complications. You might see it if you get prolonged bed rest. And because we have an epidemic on deficiencies of vitamin D, a lot of us, like myself, have been prescribed 50,000 units. Not 1 or 2,000 like you see in the grocery store. No. I was so low, I was prescribed 50. Now, of course, that's only for a temporary amount of time, and it's by prescription my doctor's following, right? So I didn't just keep that shit up for 20 years. But if I kept it up forever, then I would have a high calcium. Why? Because all of you know your renal. You have to have vitamin D to absorb calcium. And so if you overdid the D, she loves the D, then you overdid the calcium. Doesn't that make sense? Okay, you're going to be okay. This has to make sense to you. Aren't they opposites? Oh, okay. Well, that means that too low of a phosphorus would give you a high calcium. They're opposites. They're divorced. This part makes sense. Now, I love this because we have to make sense, and this is an easy way to do it. If you think of the treatment of this patient, first of all, it's hyper, and a lot of hyper people need to be hydrated. A whole lot of hyper people need to be hydrated, okay? So the first thing we usually do with a lot of these hyper people is we hydrate them. That's first on a whole lot of folks on this side of the board. Now, everything we do to this patient ends in ATE. Hydrate with what? Oh, you just ain't gonna pull any of these solution off the countertop. No, honey. Because if you hydrate them with normal saline will actually work towards decreasing their calcium. LR, what did it have in it? It had low calcium. What is you doing? You don't know your shit. You done pulled LR off the table. No, normal saline is going to decrease the calcium. It's isotonic, but it's going to decrease the calcium. Okay, ambulate. Okay. Let me take you back to ortho with osteoporosis. With osteoporosis, you were told to have your patient do weight-bearing exercises. That sounds cute, but what does it mean? It means have them do exercises where their entire weight is on their feet and their legs. Because if you have them do weight-bearing exercises like walking or treadmill or a stepper or bicycling or jump roping, then every step they take will build bone by pulling calcium out of the blood and encouraging it to go into the bone. You literally build up your bone the more you walk. So your little ass on the couch ain't gonna work so well for your little osteoporosis. Weight-bearing exercises. Ambulate if they can, right? Okay? Medicate. Medication. Medicate with what? Diuretics decrease your calcium. You might want to know that. Loop diuretics decrease calcium. You might want to know that. Calcitonin takes it out of the blood and puts it in the bone. Increasing phosphorus will decrease the calcium. So we're going to increase the phosphorus in the diet. We're going to increase the phosphorus in the diet. There's a group of medications that you probably learned in ortho called biphosphonates. These are your Fosamax, your Actonel, your Boniva. Those biphosphonates, they are medications we use to take the calcium out of the blood and put it in the bone. And then there's something called chelate or chelation therapy. Chelate. Chelation therapy is an infusion to pull calcium off the blood. Chelation therapy. Dialysate. Okay, if none of that shit worked, guess what? We need dialysis. Dialysate. Just give the patient the dialysate solution, hang it in the bag, get that calcium off that patient. If the meds don't work, that's the last resort, ain't it, y'all? Because we ain't just doing dialysis on everybody. Okay, so that's the last resort. What's the first resort? Give them some high phosphorus foods. Well, that sounds cute, but if you don't know what high phosphorus foods are, we're going to have a problem. Remember, it's dairy, beans, peas, and nuts. Dairy, beans, peas, and nuts. Pop too, but you ain't going to get this one pop. Because we ain't giving nobody pop, right, y'all? We use it for just the holidays, July 4th. And we don't drink pop no more, do we, y'all? My nurses, never. Okay? But pop is high in phosphorus. Okay, now, so that's fine. I think you get it. This is no biggie because it's the what? Opposite of a low calcium. And I spent 50 years over on that side of the board telling you about low calcium, so I couldn't tell you no more. So this is very much the same. To say high phosphatemia is a lot of the same because you can't really see a patient with a high phosphorus and they not have a low calcium. I will tell you this, because I told you that over there. High phosphorus is with kidney failure. Your patients with high phosphorus levels are always in stage renal disease and kidney failure. Number one cause, I wrote it on the board. And you know with kidney failure that every patient has a low calcium too, and the bones have, what's that annoying word? Osteodystrophy. Yeah, that word. But it's osteo though, dude. Thank God. I was like, my babies are supposed to get that right. Yeah, I will, baby. When you have end-stage renal disease, kidney failure, you can't get rid of phosphorus. You can't. You can't pee it out. So phosphorus is very high in all kidney disease. It's really, really high. End stage is the highest. So if you have a high phosphorus, who's the opposite? Calcium. All renal disease has a low calcium and osteodystrophy. Because what does osteo mean? Bone. What does calcium mean? Bone. Okay, so calcium and bone go together. Okay, now look at this. Of course, if you have high phosphorus levels, should you cut it out in the diet? You probably shouldn't be doing too much dairy, beans, peas, and pop, and whatever we said earlier. None of this stuff. So that's just common sense. It's just low phosphorus diet. Hello. But don't get goofy with this one. Don't think high calcium in the diet is the treatment. It's not. It won't work. This one needs phosphorus binders. One of your phosphorus binders in your notes, what I taught you renal a few weeks back, was Renagel. Renagel, anything to bind the phosphorus is going to help the patient. And again, a low phosphorus diet. Do not teach this patient high calcium diet, even though it's the opposite. Don't do that. Or low calcium diet. Don't do that. Okay, so what kind of treatment? Well, could be dialysis. Throw that in there. Dialysis, if nothing works, that will help a little bit. But main treatment of this patient is low phosphorus diet and phosphorus binders. The same thing you learned in renal.